This two-part video will review mental health conditions for adults for the NBCOT exam. If you haven't watched my video on mental health terminology, I highly recommend that you watch it first, as this video may contain some terms that you may not have reviewed or not be familiar with. I'll post a link in the description. Also, to get the most out of my content, I highly recommend that you not only watch this on YouTube, but also enroll in my free NBCOT exam prep course for the outlines, the study guides, quizzes, and much more. I'm Jeff, the OT dude, and let's get functional. The structure of this video will be based on categories of mental health conditions: psychotic disorders, mood disorders, anxiety disorders, cognitive disorders, and personality disorders. Did you notice a pattern, by the way, in my terminology review video for mental health conditions? Schizophrenia was a common condition reoccurring that exhibited many of the symptoms and terminologies. So let's review this first. Schizophrenia is the most commonly known one, but also let's differentiate it from schizoaffective and schizophreniform. I don't think I noticed this when I was in OT school, but schizoaffective has the word affect in it. Affect as in emotion, like flat affect. So compared to schizophrenia, schizoaffective has emotions and mood disorders and symptoms more front and center. In schizophrenia, the mood disorder is not the dominant presentation. And because schizophrenia is the most well-known of the psychotic disorders, naturally it has the most psychotic symptoms compared to, say, schizoaffective. So psychotic symptoms are more dominant in schizophrenia, but with schizoaffective, less of the case. But there may be episodes of psychosis though. And it takes a trained professional to really spot the differences between the two. So this is just the nuances to study for the NBCOT exam. Okay, what about schizophreniform? Well, one difference is in the DSM criteria. With schizophreniform, clients do not meet the criteria for schizophrenia. However, their psychotic episodes last less than 6 months. You can think of schizophreniform as a short-term type of psychotic disorder that is still characterized by psychosis. So then, OT treatment has a different focus. Schizophreniform treatment focuses on short-term symptom management, whereas with schizophrenia, it's more long-term management. To remember schizophreniform, think of the I form part of the word. So short form that you would fill out like digitally on an iPad, for example, it would be called an I form, maybe if it was made by Apple. So think of it that way. Now let's get more into schizophrenia, since it's more the well-known and more common type in terms of OT anyways. The DSM criteria for schizophrenia is the presence of 2 or more symptoms that, again, last longer than schizophreniform. For schizophrenia, they actually last greater than 6 months. Symptoms for schizophrenia can be categorized as 3 things. 1, psychotic, 2, negative, and 3, cognitive. And we already know the definition for psychosis from watching the mental health terminology video. Specific psychotic symptoms include hallucinations, including the visual, auditory, smell, taste, even tactile or feeling. Also, delusions. Psychosis may be accompanied by thought disorders and movement disorders. A thought disorder is an unusual or illogical thinking or speech kind of phenomenon. Movement disorders, like the word implies, includes repetitive movements and other abnormal body movements. In the next category, negative symptoms, these include a loss of something, hence negative, right? This may include loss of motivation, loss of interest, loss of enjoyment, withdrawal, emotional suppression, basically abnormal functioning or less of some functioning. Some more specific examples include difficulty with planning and participating in activities, talking in a dull voice, showing limited facial expression, like more flat, avoiding social interactions, having lower energy, and in more extreme cases, not moving really much at all, like with catatonia. These can often be mistaken for symptoms of depression, actually, right? Third category, cognitive symptoms, they can affect all aspects of cognition that we kind of learned in OT school. Attention, memory, planning, processing, and problem solving. One myth may be that clients who are schizophrenic are violent, but overall they are at a higher risk for being a danger to themselves or to others only if the condition is left untreated. And there are several subtypes of schizophrenia to be familiar with. Paranoid type is the most common, and symptoms include delusions, such as delusions of grandeur and hallucinations. Disorganized type, also known as hebephrenic, is characterized by primarily disorganized symptoms. Examples of disorganized include disorganized speech and disorganized behaviors. That makes it easy to remember. Examples of disorganized speech more specifically include word salad, perseverance, and more other disorganized behaviors such as difficulty with task initiation and completion, or even inappropriate social behaviors. Catatonic type is the most rarest and is characterized by limited but also sudden movements and switching between being very active and being very still. These clients may not talk very much, but may show echolalia or echopraxia. Undifferentiated type is for those who do not fit into the other categories of paranoid, disorganized, or catatonic because they have no dominant type of symptom for those types mentioned earlier, and more like a mix of them. Last is residual schizophrenia, which describes those who do not experience the previous symptoms such as delusions, hallucinations, disorganized behaviors, or catatonic behaviors, but are still considered schizophrenic. They experience at least two of those symptoms, basically to a lesser extent. And I wouldn't really worry too much about remembering these subtypes too much, just knowing and appreciating it for schizophrenia. Treatment for psychotic disorders include antipsychotic medications, psychosocial therapy, family support, referral, and managing comorbid conditions such as with drug and alcohol abuse that may also co-occur. For medications, some medications include the newer second generation compared to the older first generation ones that were used that had more side effects. Some medication side effects just in general include dry mouth, blurry vision, constipation, photosensitivity, dystonias, restlessness, tardive dyskinesias, cardiac symptoms, dizziness, and even insomnia. Second generation antipsychotics, which are more preferred than the first generation, include Abilify, clozapine, Latuda, Zyprexa, Seroquel, Risperdal, and Geodon. Also, you should know that first generation antipsychotics have a higher probability or chance of developing tardive dyskinesia, and it may not even be irreversible, so it may be permanent. And these first gens include Thorazine, Prolaxin, Trilithon, and Haldol. Psychosocial therapy includes individual therapy, social skills training, and vocational rehab / supported employment. This is because individuals with psychotic disorders may require daily living support and help with jobs, with housing, crisis management. Research shows that actually family therapy and assertive community treatment are significant for preventing psychotic relapse and preventing hospitalization or rehospitalization. Cognitive behavioral therapy, CBT, may also benefit clients who experience disabling psychotic symptoms if medications are not enough to help them manage the condition. And OTs may work with clients in the occupation of IADLs, for example, and community reintegration, such as with homemaking, parenting, by providing interventions that are indirect or direct using compensatory strategies, environmental supports, and managing maladaptive behaviors. Now we're going to talk about mood disorders. The mood disorders include varying degrees of abnormal mood from the low end, depression, to the high end, feeling euphoric with mania. But also there is bipolar disorder, dysthymia, and cyclothymic disorders, which we'll talk about. Before we go into the specific disorders, we should review what manic and depressive episodes are and kind of what they consist of. And basically, knowing these two extremes, DSM classifies them as conditions based on where they are. Do they go back and forth between them, or is there a lesser degree, like a milder case of the symptoms, or full-blown? A manic episode is characterized in the DSM by a distinct period of elevated, expansive, or irritable mood and abnormally, persistently goal-directed behavior or energy that lasts at least 1 week and is present most of the day, nearly every day. Clients may be easily distractible as well. A depressive episode, in contrast, is characterized by depressed mood, loss of interest or pleasure in activities, with weight changes, sleep disturbances, psychomotor changes, fatigue, lower energy, a sense of worthlessness, impaired thinking, recurrent thoughts of death such as suicide ideation, and impaired daily functioning. So now that we know that, let's go into more of the disorders. The most well-known of the depressive disorders is major depressive disorder. You probably already know the symptoms and kind of what depression is and probably what major depressive disorder is, so we won't go into that, but it is characterized by prolonged periods of extreme sadness. Now, to a lesser degree, we have dysthymia, and it's also known as persistent depressive disorder, PDD. Dysthymia can be thought of as a less severe but a chronic form of depression that lasts at least 2 years and has fewer symptoms than major depressive disorder. One way you can remember this is the word major in major depressive disorder, making it stand out for its symptoms, right? Compared to persistent depressive disorder. Okay, moving on. Bipolar disorder, you probably already know, but it's characterized by alternating depression and mania. Bipolar disorder is also called manic depression, interestingly. And this makes sense as there's mania and depression. It's also known as bipolar affective disorder as well, to a lesser known degree. And remember how there was a milder form of major depressive disorder for dysthymia? There's also a milder form of bipolar disorder, and that's called cyclothymic disorder. And it's basically a milder form of the bipolar disorder. You can remember cyclothymic by thinking cyclo, like cycle, and mic as in a mic used for singing. And in songs, they kind of cycle between the ups and downs. It's kind of like in those breakup or romantic songs, and you go up and down that. So it's kind of funny too when you listen to like an artist album, they may sing about love, and then the next track maybe be about breakup, and it's kind of like a cycle. So that's one way you can remember that term. I won't go into the medications because I guess I made a video about this actually already. So I'll link that in the description as well for that in terms of like depression and the medications and things to look out for. You can check that out after watching this one. In terms of impact though and intervention, we know that these disorders all across the spectrum of severity can affect activities of daily living and daily life and all occupations from work to family life to leisure. The most well-known and scientifically supported for effectiveness for the management of depression is CBT, cognitive behavioral therapy, along with medication management. Research also supports the use of problem-solving therapy, which is a cognitive behavioral type of intervention that focuses on training in adaptive problem-solving skills. For bipolar disorder in adults, systematic reviews support the use of CBT as well as interpersonal therapy and illness management. So if you're finding this video helpful so far, please give it a thumbs up right now so you can help other students like yourself find my videos easier. I would also appreciate it if you also shared this with your friends and study groups. You can also support this channel and my content in other ways, becoming a Patreon member, tipping me in the tip jar, getting some cool OTDUDE designed stickers, t-shirts, or my very own handmade badge reels to wear as a student or at work. These make great gifts too. Links will be in the description. Now back to our content. Now let's review anxiety disorders. Anxiety disorders are a broad category with more specific subtypes too in the DSM. In general, it is characterized by panic, stress, generalized anxiety that results in altered behaviors, emotions, and cognitive processing. Subtypes of anxiety disorders include generalized anxiety disorder, GAD, panic disorder, agoraphobia, obsessive compulsive disorder, OCD, PTSD, phobias such as social phobias, substance-induced anxiety, and last, anxiety due to a general medical condition. As you can imagine, the occupational impact can affect many aspects of the client, from cognitive to physical to psychosocial due to anxiety, no matter what the subtype really is, even if it's medically caused, so to speak. Medications used for anxiety often cross over and are very similar to depression, and these include the SSRIs, the tricyclics, antidepressants, and the benzodiazepines. Some familiar names of medications used for anxiety include Prozac, Zoloft, Celexa, Lexapro, and Paxil, which may also be used for depression, as mentioned. When answering questions for the NBCOT exam, be sure to avoid also certain medications due to some of the side effects for our clients, especially if you know that they're susceptible to certain side effects. These include side effects such as increased suicide ideation, withdrawal effects, serotonin syndrome, rashes, and with MAOIs, MAOs, monitoring vital signs, and also avoiding aged and fermented foods, right? Photosensitivity is another one to look out for medications such as the commonly prescribed Prozac, Celexa, and Zoloft, as well as also the tricyclics, especially if they are prone to sunburns and they may have skin issues or conditions like cancer or something. OT interventions also includes CBT, as well as interventions for therapeutic breathing, meditation, progressive muscle relaxation, stress management, mindfulness, and other relaxation therapies. Exercise and yoga are also effective as adjunctive therapies, but used alone, they are not quite effective as combined approach, such as with CBT. And outcome measures that you can use often have clues in their names, such as the hospital anxiety and depression scale, the Breck Depression Inventory, but also other ones such as the Patient Health Questionnaire 9, also known as the PHQ-9, is also commonly used. Other outcome measures to consider using are the ones that measure not just depression and anxiety, but for all really the impact on one's life, right? And how the occupations may be affected. So more basically top down, more holistic. Now let's review cognitive disorders really briefly. We basically covered these conditions of symptoms already, but more specifically, they include delirium, dementia, and amnesia, those kinds of things. Medical team management would focus on addressing what the underlying causes or the etiology is, but also to do symptom management, such as with medications. The role of the OT then is maintenance or the promotion of occupational participation for the immediate needs, such as ADLs, as well as to promote orientation to reality, because these types of clients may be disoriented or confused. And safety is also important, as patients may be aggressive and also high fall risk or confused and do not know how to safely move about or interact with their environment, or with objects or other people. Now let's review personality disorders. I find personality disorders especially interesting and either love them or hate them as well, as I have some personal experience with some of these personalities in my social relationships. I am sure some of you also do as well with some of these types, or maybe many of these types, as some of them are actually quite common and some are more so than the others. In the DSM, these are divided into actually several different clusters, but I don't think the NBCOT will test you on this exact knowledge, but this is just interesting to appreciate. But just FYI, cluster A includes the odd behaviors, cluster B, the unpredictable or dramatic behaviors, and then cluster C, anxious behaviors. And I bet that you're probably aware of 3 of these personality disorders already, such as paranoid PD, antisocial PD, and narcissistic PD. Antisocial personality disorder, by the way, does not mean like introverted or something, contrary to how it's used in like everyday speak. It's more for those who commit criminal acts or those who don't conform to the social norms of their specific culture. So there is no specific universal norm. It's really culturally dependent too, right? So what I do here in America may be taboo, so to speak, in say Australia or in the Middle East or in Canada or something. So now let's review the personality disorders that are less commonly known or people are not as familiar with. For example, schizoid PD and schizotypal PD. What's the difference or similarities? Well, schizoid PD is characterized by social withdrawal and discomfort with human interactions. Schizotypal PD is characterized by more eccentric thinking, appearance, or behaviors. One example is magical thinking. To remember this, the word avoid in schizoid, as in avoiding social situations, and schizotypal for magical thinking, right? So imagine like typing on a keyboard typing, and you know how Apple has those brands of magic keyboards? Well, schizotypal, magic keyboard, magical thinking. What about avoidant PD then? People with avoidant PD avoid social situations as well, but for other reasons than for schizoid PD, which is associated more with eccentric thinking. People with avoidant PD have chronic feelings of inadequacy and are highly sensitive to being negatively judged by others. So while they do interact with others, they tend to avoid social interactions and situations due to the intense fear of basically being rejected. The opposite then is dependent PD, depending on somebody. Those who have dependent PD depend on others as they may experience discomfort when being alone, perhaps due to a lack of self-confidence. Histrionic PD is characterized by overly dramatic or extroverted behaviors. People with histrionic PD tend to have strong opinions, have rapidly changing emotions, and think relationships are actually closer than they actually are. Borderline PD is characterized by unstable moods, behaviors, and emotions, as well as relationships. Specific symptoms include emotional instability, insecurity, and impulsivity. They tend to be overly preoccupied, especially with that impulsivity with sexuality, and so they may be hypersexual. To remember this, think of a border like the border between like 2 states or countries. And because you're not as secure and always on the move, such as like being a refugee, you're always on the move. And to remember histrionic, think of someone who is, say, in theater class or in drama, and they may be acting out something more dramatic. So say from like a historical play that is characterized by dramatic emotions, behaviors, and rocky relationships. Last of the personality disorders, PDNOS, personality disorder not otherwise specified. And it's for those who do not really fit into the other previously mentioned personality disorder categories. And one exercise or homework exercise or thinking exercise is for you to think about what OT interventions can be done for these clusters A, B, and C from what I will go over next. But not everyone type based on that personality has the same type of intervention because they have basically different personality types. And dialing down even more, each specific personality disorder, say histrionic, may even have more specific interventions. And that's really beyond the scope of this video, or this video will be like 3 hours long. But overall, such as, for example, cluster A, psychosocial treatment may include cognitive therapy that may be helpful. As an OT, you may want to be careful of being too aggressive or appearing too aggressive or hostile with the clients. And the NBCOT exam also likes to ask you questions about how you may interact with clients. So consider this and think about how you may interact with these clients, especially with mental health in general. I think these is commonly asked because these individuals, they may behave differently socially compared to, say, medical conditions or with pediatrics. Things you may want to avoid doing, for example, maybe, say, taking on an expert role and being like more above the patient or the client, and rather being more inquisitive and more flexible with the client. So you're on the level ground. You should also try to build a therapeutic alliance without encouraging or being overly dependent or forming an overly dependent attachment with the client. But anyways, general OT interventions that may apply to each of these clusters or conditions include stabilization of the thoughts and the moods and perceptions into more appropriate, healthy ways, promoting safety, improving self-esteem, developing and gaining insight, helping with, say, decision-making and judgment, such as with conditions such as borderline, where they may be more impulsive, improving interpersonal relationships, promoting a motivation for change by setting meaningful goals. From my research, I found some more specific approaches that may be helpful and effective. Cognitive behavioral therapy, dialectical behavioral therapy, impulsive lifestyle coaching or counseling, crisis management, coping strategies, and social problem solving. And you know, commonly as occupational therapies, we like to embody ADLs, right? Activities of daily living. But be careful, because as participation in, say, ADLs or even some IDLs may be prioritized, it may not necessarily be therapeutic for the client. For example, some clients may perceive self-care occupations such as brushing your teeth or showering even to be painful or to be tedious or even meaningless. So try to be client-centered, even if it means they don't do some ADLs. It may be better to engage in more productive occupations that allow clients to gain some recognition or to identify some of their competencies to improve their self-esteem. And a note about obsessive compulsive personality disorder, which I didn't actually mention with the personality disorders. OCPD is often confused with OCD, obsessive compulsive disorder. These are not necessarily the same, which is why they're different in the DSM. And I actually made a video about OCPD, highlighting that and the differences between OCD. So be sure to check that out. I'll post that into the description also. It's an interesting condition, OCPD, because it's not very easy to treat, and there's still a lot that is not known about it in terms of treatment and causes and things like that. So it's a very interesting condition to check out as well. Also, I'll be posting in the future a part 2 video that will include somatoform disorders, eating disorders, substance abuse disorders, and alcohol abuse, things like that. So stay tuned for that. And if you haven't already, subscribe to this channel so that you get notified when that video drops and is released. Good luck studying. I'm Jeff the OT Dude, and have a nice day.